Welcome to the BD webinar. This webinar is called WavelinQ EndoAVF, an option for dialysis patients. In this session, we'll be focusing on the role of WavelinQ EndoAVF fistula for dialysis access. On the panel to discuss this are some renowned experts in the field of dialysis and who will represent the multidisciplinary nature of dialysis and dialysis access care. First, I would like to introduce Professor Jose Ibeas, who's a nephrologist from Sabadell, Spain, and is the current president of the Vascular Access Society. Professor Ibeas, may I first start by asking you, as a nephrologist, what are the challenges that you see in vascular access and that your patients face?
Thank you very much, Nick, for this crucial question. The nephrologists we look for in hemodialysis patients, first of all, is the adequacy of dialysis. This is the quality of dialysis, because depending on this, is going to be longer or not the lifespan of the patients. For this quality of dialysis, we need a vascular access. And the vascular access really is the bottleneck of the quality of dialysis of the patient. For two reasons. One, because we need the higher incidence and prevalence of native AVF mainly. And second, to avoid the catheter placements. And the second option to take into account always is the number of procedures you have to do in order to maintain the patency of this dialysis access. On the other hand, the other problem that we have in dialysis patients is the comorbidity of the patients, the age, and all the related diseases that can affect dialysis access. For this reason, in this context, we have to take account all our resources, all the health system, all the hospitals, and all the things that we can offer to the patients. We have to think that in the time you have now, in these bad times, we have to think about the challenging opportunity we have to take profit in this context. And this is very important because we have to join the capacity of our professionals, our resources, with the best opportunities, with the new devices, the new knowledge, or all the new guidelines. Finally, all the knowledge that we can offer to our patients in order to make more profitable, and this only award efficiency for them, and always without forgetting the quality of life of the patients.
So, the recent surgical lockdown caused several problems for vascular access across Europe and certainly across the world. Do you think a lot of this was pre-existing problems that have just been highlighted in terms of ability to get vascular access for patients?
Sure, because even in the best centers, in the vascular access centers with the high opportunities, we have noted an important damage of these kind of problems. Imagine then in the more humble vascular centers, the vascular centers with lower opportunities. Then the problem is that in this context, if in the medium-sized center, if we have different resources, different professionals, and so on, the problem you have is that you usually work sometimes in closed boxes in different specialties, and we don't realize the opportunity we have in the other door, to the other side of the door. For this reason, I would like to highlight the multidisciplinarity of vascular access opportunities in order to take profit, probably, of the lack of resources in these kind of times. If in this context we add the question arises by the guidelines that probably we don't have to look for the fistula first, but the patient first, the condition of the patient, the context of the patient, the environment, and these different circumstances, probably as the Spanish guidelines of vascular access or the European guidelines or the Turkish guidelines, we have to join all together our the resources or capacities I told you before, we can offer the patients in probably sometimes in the worst of the scenarios to get the maximum outcomes for these patients.
So I think it's very important, very interesting that you identify the involvement of patient choice in this and in their own vascular access. I wonder if I can put that to Dr. Kitrou from Patras in Greece. Dr. Kitrou, do you think that the WavelinQ EndoAVF could be a possible alternative to surgical creation of AVFs, particularly when, as we've seen, surgical services may actually be limited for various reasons?
WavelinQ is an alternative and is also complementary to surgical fistula. It provides two additional sites for anastomosis by creating a deep ulnar or radial fistula. It also offers versatility and multiple ways of doing this by accessing wrist or brachial vessels going parallel or anti-parallel. Additionally, and to your question, in these strange times of operating theater lockdown and its future consequences, WavelinQ offers the ability to create a fistula at the time that is needed by other disciplines such as interventional radiologists and interventional nephrologists in the cath lab or with the help of a CR outside the operating theater. And I think that is what is most important for hemodialysis patients, to be able to follow their life plan and not be forced to perform dialysis via a catheter.
So, Dr. Kitrou, you've mentioned that the WavelinQ device is versatile. And I wonder if you could expand. You mentioned a few things about that, but do you mean this is versatile in terms of the access, in terms of the way that the fistula is created, in terms of the sites the fistula is created, perhaps?
Yes, this is true. And this is possible by allowing to create an anastomosis at two different sites, and also by accessing the wrist and the brachial vessels. What is more, you're not restricted to go parallel using only the brachial or only the wrist vessels. You can create the anastomosis by using, for example, the brachial vein and the radial artery, or vice versa in an antiparallel manner. That is why, once you respect the anatomical criteria, success rate is extremely high.
So, how do you go about assessing a patient to see if they're eligible for a WavelinQ approach?
Patient selection is key to success. Screening of patients is the same as for surgical fistulas, plus the presence of the perforator vein and the minimum of 2 mm vessel diameter for accessing the vessels. This is why proper mapping is crucial. You have to make sure that the vessels have sufficient diameters, plus you also need to make sure that there is a direct connection between the deep vein, where the anastomosis is created, with the perforator and the superficial vein, ideally the cephalic vein, so that blood could easily flow from the anastomosis to the cannulation zone. In this short video, we will go through the ultrasound screening process for the WavelinQ EndoAVF procedure. Initially, 4 things should be evaluated: the ability to perform the WavelinQ procedure from the wrist, to secure that there is a straight path to the level where the anastomosis will be created, the presence of the perforator vein at the level of the elbow and its connection to the cephalic vein. Vessel diameters are measured with the tourniquet on. In this case, screening begins from the radial vessels of the wrist. Diameters are checked to be a minimum of 2 mm at the access site. Presence of calcifications at the radial artery is also evaluated. The straight route to the radial vein to the site of the anastomosis needs to be confirmed. In the current case, the lateral radial vein on the right side is chosen. Next step is to evaluate vessel diameters at the site where the anastomosis will be created. Consequently, a check of a direct connection to the perforator vein and the connection of the perforator to the cephalic vein. One should also evaluate cephalic vein's diameter throughout its length to remain consistent. Ulnar vessels should also be checked. In this case, the extensive calcification of the ulnar artery prohibits its use. Additional screening should be performed for the basilic vein. Vessel diameter in connection to the perforator vein should be checked. In this case, vessel diameter is similar to that of the cephalic vein, and there is also a connection to the perforator vein. Thus, this patient will probably end up having a Gratz-like fistula. Finally, the evaluation of the brachial vessels takes place in order to know the alternative of brachial access and the possibility of coiling of one of the brachial veins at the end of the procedure, as in this case where the diameter is significant. If one decides to create the fistula by accessing the brachial vessels, special attention should be given to the nerve bundle, which should be avoided during puncture.
So in practical terms, what you're telling us is that the assessment is very similar to that for a surgical fistula. I know that the device developed over some time now and has moved from a 6 French device to new iterations of a 4 French device. And this new innovation of a 4 French device, I think, would be very useful to hear about from Dr. Tobias Steinke, who's a vascular surgeon from Germany. He has experience of each iteration of this device. Dr. Steinke, has the new 4 French device altered your approach to fistula creation and eligibility?
Hi, Nick. Thanks for the question. Yes, I've been involved in the development of the catheter technology since the beginning of the EndoAVF area, and I'm quite happy to be part of the development of this technology. And as you know, the international exchange with you, Rob, and all the other colleagues in Europe, as well as with the engineers of the company, has made it possible for both sides to create the technical possibilities we do have now for a successful device. Here you see the new next generation 4 French device, which is really an improvement because we do see a lot of more magnets which are able to adapt both catheters much better, especially in a curved anatomical situation. What really helps is the additional rotational indicators you just see beside the electrode and the backstop. So you got really perfect orientation of your anastomotic site. And in the future, we will also get a new RF generator, which is much lighter and easy to carry. So that's really a step forward. The rapid exchange tips are still there, and that makes the insertion of the catheters through the sheath really easy. On the slide here, you see the perforator, which is marked in yellow and which is really important for the procedure. If you do have a good perforator, the flow is very well directed to the superficial system. And it's on the ultrasound, you just see a cross-section of the proximal forearm where you can identify also the radial artery and the median cubital vein. And it shows the anastomotic sites which are possible, which is the proximal ulnar and the proximal radial artery and veins. And I'm really happy to show you the first use in Europe of the next generation 4 French system. Those are pictures just out of our OR where we performed it just a few weeks ago. We always try to start with a venous puncture, which sometimes still challenging, even if you're more experienced and using a dedicated ultrasound machine. And after placing the sheath, we just do venogram to get an overview of how the venous anatomy is like. In this case, you see on the right side the venogram where we punctured the lateral radial vein. You find a little bit of spasms there, which you might be able to relieve by using nitro or gentle injection of saline solution. And on the right side, you see a perfect outflow. You see a perforator, which is quite big, and a basilic vein and a cephalic vein, which is suitable for the later puncture. On this picture, you see both sheaths already in place. So after doing the venous puncture, we perform the arterial puncture at the wrist. This is a radial access. And then we do an arteriogram to show the architecture of the vessels. I may just put your attention to the right picture where you see the wire inside the lateral venous vein. And in a lot of patients, you see that the wire crosses from lateral to the medial side. So that's the point where the tip of the catheters may end. Otherwise, the catheters are going to cross. And then it might be more difficult to place them just parallel in the vessel architecture. I'm happy to show you this picture out of one of our first procedures with the next generation 4 French system. As you can see quite clearly, the benefit of the additional rotational indicators, which are just beside the backstop and the electrode, which really helps to find the right orientation of the catheters. And that the electrode and the backstop is perfectly orientated to each other, that you have the right direction of the cut by the RF energy. On the right side of the picture, you just see what I've been talking about before. You see that the lateral catheter is trying already to cross to the medial side. So that's something you have to pay attention to, but the electrodes and the rotational indicators on the right side, on the proximal side, are still in the perfect position as well. On this side, you see the final fistulogram, which is injected with a little more pressure, so that coming from the radial artery, the contrast media, just go up into the brachial artery, and you also get a contrast in the common ulnar and ulnar artery. The anastomotic side, which is kind of a jelly bean, is marked here with a red circle. Sometimes you get a little bit of spasm proximal in the vein, but normally that resolves over time. The perforator is very well filled with the contrast medium, and you see already the slow filling of the basilic and of the cephalic vein. So that's a good result of a proximal radial EndoAVF created with the WavelinQ EndoAVF system. If you do look at this illustration, you find several things to notice. Down near the logo on the right side, you find the EndoAVF tract after being recanalized, and you find a nice endothelium on the surface, so that you have a really nice perfused EndoAVF fistula. You see the position of the perforating vein, where you get the split flow into the cephalic and into the basilic vein, so that you have the possibility to puncture both veins for the dialysis session. And to summarize it, multiple outflow vessels are able to dilate and mature. The lower flow rate through any single vessel might be beneficial because you have less stress and maybe less aneurysm formation. The excess by just puncturing the vessel causes less vessel trauma, less scarring, and because of that, maybe less juxta-anastomotic stenosis and shrinking. And it also has the benefit that it preserves future surgical options. You're still able to do a surgical fistula at the level of the elbow or just above. And sometimes after maturation, you're even able to do a more distal radiocephalic fistula because the cephalic fistula of the forearm matured as well.
So a common question we get is, this is a fistula in the deep system. Number one, how does it get to the superficial system? And to do that, to increase maturation, does it need an angioplasty? Does it need coiling? How does it move blood from the deep system to and encourage blood to flow from the deep system to the superficial system?
Yeah, we just rely on the perforator vein, which is able to bring the blood flow up to the superficial system. And in principle, the WavelinQ system, as approved, does not require intraprocedural angioplasty. And I personally do not consider to do a PTA because we know that PTA alone may damage the vessel wall, which is considerable stimulus for a restenosis, so no PTA at the first step. And coming to the question of coiling, you should answer it like coiling is helpful in patients where the deep veins and the perforator just compete for flow. The venous anatomy is extremely variable at that point, and we are still learning. Some patients have just limited collaterals and limited circulation around the cubital artery, and they just don't need a coil. Others show a large lumen of the common ulnar vein is directly connected to the brachial vein, and there you definitely have to place a coil to direct the flow to the superficial system. But it's always an individual case decision, but I'm really convinced that coil accelerates maturation in many cases, and it's not time consuming, the procedure is safe, and it's really quickly done.
So the fistula is created below the elbow and has multiple outflows through the perforator into the cephalic and basilic vein, I presume. Does this give any benefits to this fistula over elbow fistula?
Yeah, I think you get less shear stress, and by having multiple outflow vessels, you get more options to cannulate the patient. And if you have a reduced flow in each vessel, you may have less aneurysm formation. So for the patient, I think it's an aesthetic benefit, and for the nephrologist and the nurse, you just got more vessels to puncture, which is a benefit for both, for patients and nephrologist and nurse.
Dr. Kitrou, have you got any comments on that? Do you find that it has benefits over, or other advantages maybe over, a surgical fistula at the elbow?
So far, we have performed more than 30 cases and only 3 of them failed to mature. This is more than 90% success. In about 75% of the cases, we had to coil one of the brachial vessels in order to assist maturation. However, one thing is for sure: the more familiar you become with the ultrasonographic and the angiographic anatomy of the forearm, the easier it becomes to find patients that are eligible for the WavelinQ procedure.
So, aside from these technical points, I wonder if I can ask Professor Ibeas whether or not you think that nephrologists are fully aware of the percutaneous options and perhaps some of these advantages that there might be.
This is a crucial point also, Nick, because this is really the key message of any interdisciplinary team. It means that any professional of this kind of team should know how it works the other one. And it's a pity really that probably the nephrologists, they don't have, or we don't have really all the knowledge related with these kind of procedures. And this is very important because nephrologists can lose an important number of advantages of different kind of procedures. But the same for vascular surgery interventional radiologists. We have an important lack of perspective. The vascular surgery radiologists, you know very well your outcomes: immediate failure, primary failure, primary patency, secondary patency, and all related procedures that you need to maintain the vascular access patency. And the nephrologists, we know very well the KTVOV, the survival of the patient, related with the hemodialysis, hemodiafiltration online, that is the high quality hemodialysis and so on. And we don't know sometimes that all these go together. And sometimes, if we don't know how it thinks the other, we are going to lose a lot of opportunities to increase the quality of life of the patient related with the vascular access. For the reason, I would like to highlight that, like in other techniques related with catheter, central venous stenosis, with different kind of grafts, cervical enrolation, and so on, in the vascular procedure, fistula creation is probably a change of paradigm in the fistula creation that the nephrological community can be benefited. The problem of this probably is how to canalize all the information to the nephrologist community, where we are really worried with the quality of dialysis, and sometimes we forget that this starts with the bottleneck that means the vascular access. For the reason, probably we have to change our way of working, and really we have a problem sometimes because, for instance, with guidelines, the guidelines are focused depending on different societies. Society of Nephrology, of Radiology, of Vascular Surgery, and sometimes we highlight the different procedures related with our specialty, with invited people of other specialties. But we would work all probably in a common manner in order that we don't forget never to review all related concepts with the vascular access, but the front specialties to have the best benefit. And this is related with the first question that you made, related with what about these new times, these bad times, the new procedures, the new challenging situation with the new devices and so on. And from a perspective, the new community of patients with a huge comorbidity and the problem of how to create the best vascular access with a lower number of procedures, but with a very cost-effective balance. And this is a point really. And for this, if we don't know all of us all the knowledge related with the other one, we are going to lose an important benefit for the patient that finally is going to have a huge repercussion in who is going to take the decision of what to do with this kind of procedure. And this is the administration of the hospitals, who depends to administrate the whole resources of our systems.
So I think this device, we can say, is an exciting and new option for vascular access. And there is evidence so far that supports the efficacy and the safety of the WavelinQ EndoAVF AVF system. I think moving forward, there are new studies in place and that these are imminently about to start. And I know Dr. Kitrou is involved in this, and I wonder if you'd be able to highlight and comment on some of that, the move forward in terms of some of the studies coming together.
The WavelinQ program started with small proof of concept to larger studies, proving the safety and efficacy of the device. Now, there are 2 studies ready to start, one in the United States and a global one, where Dr. Inston, Professor Locke, and myself are the principal investigators. More than 400 participants will undergo the WavelinQ procedure in these studies. I'm very optimistic both about the studies and the outcomes and the evidence coming from them.
Regarding these studies, do you feel that the studies so far reflect real life and actually reflect what's happening in your practice?
Both the European-Canadian post-market study and the ones ready to start are real-life studies, and this is very important. If you're asking me about the impact on my practice, I should tell you that the device radically changed my practice, as I'm now able to create fistulas, not only rescue them. Also, the outcomes available supported my findings, so I now feel more confident.
Dr. Steinke, I wonder if you'd be able to say what sort of evidence-based that you would like to see from a surgical point of view.
From the surgical point of view, you're always confronted with people and patients just rejecting surgical procedures. So we're always looking for procedures which are minimally invasive and bringing better primary and secondary patency. So every study which helps to prove the efficacy is really helpful to get a place for the device in the field of AVS creation. And I personally think, because I'm enthusiastic about endovascular procedures, that endovascular AVF creation will be the future for selected patients. We still have to do distal or wrist fistulas. We do have a suitable patient, but I think endovascular procedures will play a really big role in the future.
Professor Ibeas, is there the same outcome measures you think the nephrologists will be interested in, or do we need to look at other things like quality of life?
Yes, this is probably a question related with the previous one, because the most of the outcomes are similar. It is related with the patency of the vascular access. But sometimes we, the nephrologists, we miss some outcome related with the hemodynamics, with the long-term benefits, or related with the hyperplasia physiopathology. This means that probably with these promising results of these kind of procedures, that we are waiting for promising results in the medium-term follow-up. Probably what we like to know is what about the all related with the hemodynamics, not only in the arm, but also in the heart, are related to the cost benefit in a context where the different kind of reimbursement of different countries probably are related with a more easy probability of to use these kind of devices. For us, one of the crucial points is probably to demonstrate that really this decrease in the relative procedures to maintain the patency of this vascular access are related with the efficiency of these procedures. And in this context, having taken into account all related with cost-benefit balance, or related to the hemodynamics of the vascular creation, or related with the physiopathology of the intimal hyperplasia, that probably this kind of lateral anastomosis is going to be very, very low. Probably in the medium or long-term results, probably we're going to get very promising results that will be translated in our outcomes and probably in the cost-benefit, not related only with resources, but also with the quality of life of patients. In fact, one of the more important outcomes in nephrology is the quality of life related figures. And this is very important because sometimes, from the economic point of view, and even for the European Commission, when we want to get money in order to make a research investigation, are one of the more important ones, and not only, as I told you before, related with clinics and money, but also with this last one.
Okay, thank you very much. And I would like to thank all the expert panel for sharing their insights and experience here. I think in summary, the WavelinQ EndoAVF, as we've discussed, has been shown to be a proven, tested, safe and effective option providing vascular access for dialysis. Equally, I think the role of the multidisciplinary team has been shown to be essential in providing appropriate patient choice and involvement in their care, which is becoming much more important from modern guidelines. Overall, to enable the best practice in vascular access for dialysis, I think it's increasingly important that all options should be considered, and this will allow the best outcomes to be achieved for each patient on an individual basis.